Welcome to Oncology Today, optimizing the role of CAR T-cell therapy in the management of multiple myeloma. This is medical oncologist Dr. Neil Love, joined today by Dr. Surbhi Sidana from Stanford University in Stanford, California. To begin, Dr. Sidana commented on the long-term outcomes for patients with relapsed refractory disease. The issue of, quote, the plateau or lack thereof with myeloma and CAR T, for example, as you made the analogy to a lymphoma or diffuse large B cell, where does that stand nowadays, particularly with more evolving data?
Right. And so we have the plateau envy with our lymphoma colleagues, as you alluded to, Neil. And what I see, right, we don't know yet what the 5-6 year data for CARTITUDE-4 might show. Maybe there'll be a plateau in the earlier line setting. But right now, we do continue to see a steady but slow relapse rate. And, nothing in myeloma so far has been curative. And, in lymphoma, autotransplant was curative for a proportion of patients. In myeloma, that was not the case. So maybe myeloma, for some reason, is just resistant to cure. But I'm optimistic that perhaps a fraction of these patients in the earlier line setting can be cured. We don't have that data yet.
Yeah, I was just sort of flashing on the fact, is there a plateau after autologous transplant?
We don't see a plateau for most patients after autologous transplant. After allogeneic transplant in myeloma, we see that these 10% of patients who are these long-term 20-year survivors, but we cannot predict who these are. So for the vast majority of patients, I counsel them that we won't see a plateau. There's always these rare exceptions.
So, and of course, that brings up the question I hear from oncologists all the time, which is CAR T going to replace autologous transplant? Are there ongoing trials looking at CAR T in the first-line setting?
Yeah, so I think that's an excellent question. And of course, autotransplant has been around for 40 years and nothing has been able to beat it. But maybe finally it has met its match in CAR T. And there's lots of ongoing trial in early line setting. The one that directly answers this question about whether CAR T or auto transplant makes sense in the first line setting is the CARTITUDE-6 trial that looks at patients who are transplant eligible and then randomizes them 1:1 to either get cilta-cel or autologous transplant after an induction with daratumumab, bortezomib, lenindex. So standard of care induction, and they either get CAR T or transplant and then len maintenance. And so this trial is ongoing. It's a 750 patient trial that's just started in the last year or so. So we'll take some time to answer. There are other trials in the transplant ineligible setting. So the CARTITUDE-5 trial tries to answer this question of using cilta-cel versus VRD. And I think more to come on that.
Would you care to make a prediction?
I think if anything can beat transplant, it's CAR T. So I am really rooting for CAR T, but it's been very difficult to beat transplant. So I hope, CAR T is able to have superior efficacy in this early line patient population.
Seems like it'd be a lot easier on the patient, I think. What about in terms of efficacy? Also, I guess another question would be sequencing. And now we have
Right.
bispecifics available, and you're bringing up this issue of prior anti-BCMA therapy. But it
Yeah.
also, I think, as a prelude to that is the issue of eligibility. I think there's a general perception that there are quite a few patients who would not be considered eligible for autologous transplant that might be considered for CAR T. How do you think through that question in terms of age, performance status, comorbidities?
Yeah. So I think, that is an excellent question. So for autologous transplant, of course, we have done so well with autologous transplant in terms of low non-relapse mortality, in terms of good success rate by doing good patient selection, right? And it is a lot for patients to go through for a month, right? And if someone is starting out suboptimally, it really does knock them down. So sometimes now in the era of very effective therapies, I counsel my patients who might be above the age of 70, who might have a few comorbidities like cardiac or, pulmonary issues that, hey, if you're looking at an overall survival to get you 15 years, we may be able to get by without transplant, right? Now, under 70 and high-risk patients are a different category where I still strongly recommend transplant for its PFS benefit. But I think CAR T is easier to tolerate in terms of patient quality of life. In fact, when I was a fellow several years ago, we did a study looking at quality of life of patients of CAR T versus auto transplant and how much dip there was. And clearly, the nadir or the dip at week 2 was much more in the autologous transplant compared to the CAR T. And both seem to recover by 1 month, CAR T a little bit more so by 1 month than the transplant. So I tell my patients it's a little bit easier in terms of just the physical ability to tolerate CAR T. And we have seen with real world data that despite a lot of patients who are coming, now transplant frontline, and so patients are not as beat up. CAR T, for these studies was 5th, 6th, 7th, 8th line. So patients were quite beat up, had a lot of comorbidities, and yet they seem to do just quite well in terms of efficacy and tolerability, which we think will get even better as we move it to earlier line. So I think it's easier for patients to tolerate CAR T. I think for referring doctors, the message should be, if you think a patient's a borderline candidate for CAR T, you're not sure, do refer them to at least have a discussion about pros and cons about CAR T, because we have done CAR T in patients above the age of 80, and they've done just well with the right patient selection. And my colleagues in lymphoma do this all the time with Axicel. In fact, they presented some of their data at the ASH annual meeting in 2024. And for the right patients, we've seen this now in myeloma and lymphoma above the age of 70. In fact, the outcomes seem to be the same, if not better, for patients above the age of 70. So I would say age and comorbidity should not be stopping for patient referral. How I think about sequencing, I think, Neil, that's a very interesting question, right? So the landscape is evolving. So what I think now might change in a year from now. But so far, our data tells us if you use CAR T in patients who've had a continuous exposure to a BCMA bispecific or ADC, so the continuous exposure, beats down on the antigen for bispecific, also impairs T cell health, the CAR T may not perform as well. The other way around, so if you've had CAR T, then you get a treatment-free interval of 1 to 2 years or longer, we seem to see a very high efficacy, almost similar response rate with the bispecific after CAR T. And if I am given a choice, I will try to choose CAR T first for a patient where I can get them to CAR T safely if they're willing to relocate and go through all of the logistics. So CAR T first and bispecific at relapse. Now, if they relapse early, within a year of CAR T, maybe I'll use talquetamab, which is a GPRC5D targeting, so change the target. But if they relapse late, I have used teclistamab with significant success as long as they still have the antigen, because antigen loss is not a very big problem in myeloma.
I'm curious whether a patient in their 90s, who, the rare patient without any comorbidities, very good performance status, what the oldest patient is, just based on age that you would give CAR T to.
Yeah, so I think I have not yet taken any patients in their 90s to CAR T. I have not heard about that from other colleagues too, but we're actually going to be looking. So we have this real world consortium, and we're going to look at patients above the age of 80 and how they do with CAR T. I will tell you this, right? There are some safety and efficacy trade-offs between cilta-cel and ide-cel. So these older patients, especially if they're frail, maybe ide-cel is the CAR T for them instead of cilta-cel, which really, when you start out here, it might take a little bit punch out of you if you get these severe toxicities. So maybe above the age of 80, 85, we have to consider these safety trade-offs much more.
I'm also curious, we had a case presented of a patient who, I don't know if they were homeless, but they had no family whatsoever, and somehow they managed to get the patient CAR T. And I'm just curious about this requirement to have a friend or family kind of stay with the patient in the hospital. How hard and fast of a rule is that? And can you get other people? What do you do when you have people who don't have anyone?
Yeah, I mean, this is tough, I will say, when you come to the practicalities of CAR T. So you have to be, the FDA requires that the patients live near the treating center for 28 days, a month after CAR T. And each center, the caregiver requirements might be different, but most centers want you to have a caregiver. So part of this time they spend in the hospital. Each center is different. They might spend a week or 10 days in the hospital. For us, we have them do CAR T in the outpatient for cilta-cel, then admit them for a few days, then discharge them. And so the requirement is not for the hospital. The requirement is when they're outside of the hospital for them to have a caregiver if they develop weird neurotoxicity or some kind of fever that they bring in. Now, in the situation where patients don't have a caregiver, things like friends or people have hired caregivers, which can be a significant financial burden. So it doesn't have to be a friend or family, just a responsible adult, and it can be different people. But if you don't have anything, like, would you put a patient in the hospital for 28 days? I don't know if that's what they did in the case that you described. I haven't done that, but that would be a consideration if that is no other choice, because this is a very effective therapy. But I think what we really need to change, and this is something we are all, starting to petition the FDA about as societies, as pharmaceutical companies, as academic institutions, is, do they really need 28 days? Because for most patients, new development of toxicities, of neurotoxicity or CRS for CAR T and myeloma at least, is rare beyond the first 15, 16 days. So if it's resolved by 15, 16 days, can these patients go home? And so I think this might evolve as years come.
So I never know if I'm the last person to hear about something or really not too many people know about it. But I was surprised when you said, quote, you can measure CAR T cells. Like, how do you do that?
Yeah. So this is not an assay that is a CLIA certified assay that's commercially available, but you can do that in a research setting. So we do that by flow cytometry. You can also do that by PCR. We do that at our institution. So we have developed our own in-house assays. Now, with these clinical trials, all the companies had their own assays by flow or PCR. And many other centers had their assays, but it's not something, you could order at a Quest lab or send to a center for that. But what that
Right.
helps if you have it is to see if someone has a weird toxicity. Well, is this CAR T related? Do they have high CAR T levels or not? So that's helpful for us in real time as we treat our patients.
Is there correlation with lower CAR T levels and less efficacy?
So that is a subject of ongoing investigation. I think what we know is that dose level correlates. So for the ide-cel trial and the KARMA clinical trial, at the lower dose level, the efficacy was lower. At the higher dose level, the efficacy was higher. And of course, expansion was lower at lower dose level. So you can make an inference from that, but it's not a direct comparison. But we are looking at in real time, does expansion matter for efficacy? And what I can share, Neil, is from our early look of our data, it's not published, that it actually probably matters, more so for safety and probably for efficacy as well. But the question about persistence, we don't know that.
You mentioned the issue of comparison, and I was really struck by your study comparing, cilta-cel and ide-cel. Of course, this comes up all the time in oncology. We were just at the San Antonio Breast meeting. They have, multiple CDK inhibitors, multiple SERDs, et cetera, et cetera. So everybody's always confronting this issue of indirect comparison. And I thought it was interesting to see you first go through the data of the two agents or therapies and then go through your more sophisticated, really cool analysis. I've never seen anything like it. I kind of felt like the eyeball test was almost a bit more effective than looking at your paper, to be honest with you, because when you just see those response rates, you immediately kind of, sort of know what's going on. But I'm wondering how this translates to your recommendations. I don't know how often, there's a time when you didn't have much of a choice. There was a dearth of available CAR T. You took whatever you can get. I think I've heard that things are pretty good right now. So if you're in a situation where you can do either, do you use cilta-cel for everybody? Do you use, what about the issue, as you mentioned, the older patient with comorbidities? And I wasn't the unusual toxicities, I understand, second cancers, but what about just basic CRS and ICANS? Does that seem, both in your experience, your trial, and the data, does that seem different? And who do you recommend which for?
Yeah, I think that is a great question and probably the multi-million-dollar question, right? Which CAR T to use now that the supply has caught up with the demand? In clinic, we could give both. And I think you're also right. The eyeball test we all had, was like cilta-cel has more efficacy and maybe a little more toxicity. And our analysis just confirmed that in a more, statistically sound way. So the way I counsel my patients is I go through data for both. Clearly the efficacy is better for cilta-cel and the durability is better, but there are some trade-offs for safety, for delayed neurotoxicity, and for some patients that's a deal breaker. They're like, I have had Parkinson's in my family, and I wish not to go through that, especially if we know it's not reversible for sure. And that's a deal breaker. I would take something with less efficacy because I know many things are coming down the pipeline for myeloma. But for many patients, especially if they're young and fit, they're like, I want a treatment-free interval that's as best as it can. It's a small risk. I take risk with everything, and I take that chance. So I will counsel my patients. And I think for older, frailer patients, perhaps I'll counsel them more, in terms of the efficacy and safety trade-offs, to really look at the safety trade-offs. But I would say a majority of the patients are getting cilta-cel, but some patients choose ide-cel for the delayed neurotoxicity, and they also choose it for, if they're frailer and older. Whether it's the right thing or not, I don't know, but that's the thing that is happening in most of our clinics right now.
Also, I was going to ask you, in terms of this GPRC5CD CAR T, do you see the same kinds of issues toxicity-wise that you see with the bispecific talquetamab, like the taste things and stuff like that?
Yeah, so it's very interesting. So the target is the same, but the toxicity profile appears to be a little bit different whether you target the same thing with a CAR T versus a bispecific. So we see less taste and skin changes, and even when they happen, they're more transient because the CAR Ts probably go up and they come down in terms of persistence, whereas with talquetamab, the persistence is more long-term. So we see that the taste and skin changes happen more often and they persist for several months. So that's less of an issue with CAR T. What we do see is the cerebellar signal, is that 10% of patients get this non-ICANS neurotoxicity with balance issues, gait issues, which we didn't see with the talquetamab clinical trials. Now, we're seeing some case reports here and there with talquetamab when it's used in the post-marketing setting of that. So it might be more common with CAR T. Maybe they penetrate the CNS better compared to a bispecific antibody. So some differences.
Can you talk a little bit about what you recommend in terms of follow-up in the community setting of patients who've had CAR T? First of all, in general, in terms of what to do in terms of infection, IVIG, et cetera, but then also in terms of specific issues, for example, the Parkinson's and cranial nerves. Like, do you recommend sort of a screening questions, or how do you follow these patients up?
Yeah, I think it's a real responsibility on the CAR T center to educate both the referring providers and the patients, almost like a survivorship document. And so, of course, we have to monitor for relapse. That is very common. So every month, these patients should have labs that look at both the myeloma labs as well as any risk for hypogammaglobulinemia and blood counts. So if patients have hypogammaglobulinemia, so IgG less than 400 milligram per deciliter, in my practice, I give them IVIG as needed. And for some patients, and that's few patients, but despite having good IgG levels, if they're having recurrent infections, I might still give them monthly IVIG. And this is usually done at the referring doctor's clinic, so they don't need to come back to the CAR T center for that. Same thing, right? If they have low blood counts, I might follow their CBC more often in the first few months, even more often, like every week, till they recover. And they might need GCSF if their ANC neutrophil count is less than 1,000. If their platelets are low, they might need TPO agonist for a long time. That's a few patients, but that's where I would say talk to your CAR T treating provider about the TPO agonist if they're needing a lot of platelet transfusion. That doesn't happen very often. I think for the delayed neurotoxicities, educating the patient, because the first person to recognize this is either the patient or their loved ones. Like, we see small changes, like changes in gait, personality changes, like my husband or wife is not the same as they were, before, and I've known them for 30 years. Something's changed. That's something they recognize very often. Change in handwriting, like mycographia, is one of the early signs. So educating them. I think seventh cranial nerve palsy is very easy. They wake up one day with a facial droop. It's very obvious. But I think talking to the referring doctor that when this happens, really call the CAR T center, and that might be worth sending the patient back for a visit to see how we can co-manage this patient, because these are something, that's not very common. This is something that can have some nuance in terms of management. The one other thing I did not mention is we are seeing colitis after CAR T cell therapy. So after BCMA targeted CAR T cell therapy, we put out reports from our real world consortium. It's rare. It was not seen in the clinical trials. And it's seen both after ide-cel and cilta-cel, the more commonly after cilta-cel. And patients might present weeks and months later with profound diarrhea and no underlying cause, right? You've ruled out infectious causes, you've done a colonoscopy, they have some inflammation, might look like IBD, but it's not IBD. In fact, sometimes it might say, oh, this looks like graft versus host disease, but the patient's never had an allogeneic transplant. And so the way we have to treat them is with a lot of nuance, with IBD targeted drugs and sometimes immunosuppression. So that's another time, when you have a lot of diarrhea or these unusual things, to send the patient back.
Yeah, I saw that paper from the Blood Cancer Journal, and I'd never heard of that. Colitis is it thought to be like sort of an autoimmune thing?
Yeah, so it's either autoimmune or CAR T, CAR T cell driven immune. And I
Right.
can describe like a patient of ours where we saw this colitis, which ultimately turned out to be a T cell lymphoma. And there might be a spectrum, right? You start with certain level of CAR T cell infiltration. At some point it goes unchecked, might become a T cell lymphoma in the gut. And this patient presented 2 months later with just so much diarrhea, lived like 2, 3 hours away. Every investigation under the sun didn't turn up anything. And when we come here, they're like, this patient has GVHD. And we call our pathologist and say, well, this patient doesn't have an allogeneic transplant. And then later we do more investigations. We actually find CAR T cells in there. Many of them turn out to be clonal eventually several months later. And we are saying it's T cell lymphoma. We gave them IBD targeted drugs like vedolizumab. And it seemed to work for a while, and steroids, then it got worse. Ultimately, cyclosporin worked for this patient, right? So this is very nuanced between it being inflammatory. In some cases, it might be underlying T cell lymphoma. There's probably a spectrum, and I think needs close management with an expert GI, expert pathologist, and a CAR T physician.
Yeah, I was going to ask you about T-cell lymphoma. We were at ASH doing some CME meetings when that report came out, and then we were asking all the people in our meetings, what do you think is going on? Right now, what's the thinking about T-cell lymphomas? What do you say to your patients about that? I've heard some people question whether or not it's uncovering something that was there before. What's the current thinking?
Yeah, I think our thinking is evolving, but what we know so far is it's probably a spectrum. One thing is it's rare, right? So there was such a big concern about it raised in 2023 when the FDA started an investigation about this. And it does happen, but it's rare, right? And it might be two things. Somebody's already predisposed to it, and they might have clones already at low levels. And because patients are so immunosuppressed, there's low immune surveillance, these clones expand post-CAR T. The other rare thing might be, does the CAR T actually insert next to where the T cell genes are for T cell lymphoma and cause proliferation? I mean, that's rare. It's possible. So those are the two hypotheses. But I would say T cell lymphoma is exceedingly rare. What's more common to happen is second primary malignancies that are myeloid, so MDS, acute leukemia, either because of the CAR T cells making it worse, but there's also a lot of immunosuppression and predisposition from the transplant, IMiDs, everything else. It's all a cascade.
Yeah, I was curious from a practical level what you say to an educated patient. I'm sure you've had physicians, you might have had oncologists who were patients who really could understand the data. And so one of the slides you showed, I think it was a real world study, it was like a difference between 1 and 9%. What do you say in terms of, if they say, can you give me a number? What's the chance you think that it's something that I might get a second cancer? And how much of a difference is there between the two products?
Right. And so I think we have to take that with just again understanding that the follow-up or survival is different between cilta-cel and ide-cel. That was actually data from the clinical trial. And the cilta-cel patient where the median PFS is 3 years, and ide-cel where it's 9 months. So, patients with cilta-cel are living longer, so have a more opportunity to develop second cancers, right? And I think it's very hard to estimate exact numbers for patients, but in our real world data, for 1 year follow-up with cilta-cel, our numbers are tracking exactly with where the trials showed for late line settings. So at 1 year, the risk is about 6%, and it goes up with time. So what I tell my patients, it's a risk-benefit calculation. Of course, the efficacy is so much more with all therapies, with any kind of cancers, right? It's a trade off. And it's not just true for myeloma, it's true for everything else. For the majority of my patients, I think the trade off makes sense in favor of CAR T. I think the one place where it really is a true trade-off. So when you are, DARA refractory after 2 prior lines of therapy, you've seen all, 3, 4, 5 drugs for myeloma, then I think the trade-off totally makes sense. I think where the trade-off needs to be discussed is in the second line setting. So after 1 prior line of therapy where cilta-cel is approved. And for Len refractory patient. Now somebody got VRD, bortezomib, Lendex, transplant and Len, and they're relapsing and they've not seen DARA yet. Now, that's where the nuances of the trade-off come. Should we do it CAR T now? Should we wait for you to become DARA refractory? And that's an individual discussion. I think for patients who are very high risk, relapsing after 18 months of first-line therapy, or patients who've want that treatment-free interval, I think CAR T makes sense for them. For other patients, they might choose to wait till, second relapse for CAR T.
How important is the issue? You mentioned the fact, I think with cilta-cel, there's a correlation between tumor bulk or the amount of tumor and toxicity. How important is it to try to reduce or do bridging therapy? What kind of bridging therapy do you do? Would you ever do a bispecific as bridging therapy?
Yeah, Neil, I didn't have time to present all of that data, but what we are realizing is bridging therapy is critical. And we are realizing that from, clinical trials and real world data in late line setting, but also from the KarMMa 3 and CARTITUDE-4 clinical trial. So many patients in this early line clinical trials where you would think it would be so easy to take patients to CAR T, manufacturing time is 4 to 6 weeks. There was a significant dropout in the CAR T arm in both the CARTITUDE-4 trial and the KarMMa trial, to the point that it caused an initial detriment in the CAR T arms because many patients couldn't even reach to CAR T. This was the topic that led to an ODAC with the FDA when they were considering earlier line approval last year in March. And what turns out is bridging therapy is critical. So in my opinion, effecting bridging therapy, because many of these patients couldn't get to CAR T. Why? Because they were progressing before they ever got to CAR T. And if you gave them CAR T when you go into disease progression in these early line trials and also in late line setting, they have a lot of toxicities. They had poor, dismal outcomes in terms of efficacy, and many of these patients, died from toxicity or rapid progression. So important, very important, cannot emphasize this enough. The most important thing is effective bridging. And I do a lot of bispecific bridging now, not for early line CAR T patients because, talquetamab or teclistamab is not approved in early line setting. But if someone comes to me as fifth line setting, they're kind of out of their standard options, we'll collect them because we don't want to do bispecifics first because that can impact their T cell health, which can lead to failure to manufacture successfully. But after apheresis, what we've done very commonly over the past year is talquetamab for bridging. In fact, we presented this data at the ASH annual meeting where we presented close to 100 patients who got talquetamab as bridging therapy. We're writing this up right now. And the safety for CAR T was not impacted. Many patients responded to talquetamab. And anecdotally and looking at the cumulative data, it's safe to do so. The safety with CAR T, in fact, is improved after they go into CAR T with deep responses. I think that is one of the best strategies ever.
I have to ask you another question, and I'm just generally curious about in myeloma. It's interesting. The day that belantamab was pulled off the market, I happened to be doing a video interview. We were interviewing a bunch of patients with myeloma, and one of them had been on belantamab for 4 years. And I heard a lot of positive stories about belantamab before it got pulled off the market. Now, of course, with the new data that's come out, people are really wondering where it's heading. You mentioned the issue of not using it before CAR T, but just putting aside the issue of CAR T, any thoughts about belantamab? I don't know how much experience you had with it. Did you have some patients who really did well? Are there situations right now where you'd like to be able to use it?
Yeah, so I think belantamab or belamab is a very interesting comeback story in myeloma, right? We don't see this very often. Something's on the market, pulled off, and now in phase 3 trials is showing superiority to daratumumab-based combination regimens. I mean, how often do you see that, right? So the advantages for belantamab are it's given less often, right? It can be given every 3 to 4 weeks. And over time, a lot of us started to use it every 2 to 3 months, and it's well tolerated. It can be given at community centers. So with bispecifics, also you need to learn to manage CRS and ICANS, and you need to have, tocilizumab. And not a lot of community centers want to have that or want to, go through the complexities of that, right? So a lot of community doctors can give that in any infusion center. So that is good thing. So patients who don't have access to either tertiary care centers or community practices who want to give bispecifics can get that. The trade-off, of course, is the ocular toxicity, right? Which can have a significant impact. So we see blurred vision, we can see, this can expand over time to more significant blurred vision in many patients. It gets reverses when you stop it. So many patients tolerate it well, but when you get blurred vision, that's a problem. So I think where it comes in, to me, I still think CAR T or bispecifics come first if somebody has access to them. But if somebody doesn't have access to them, they live somewhere rural where there's only one infusion center and the next, big infusion center is 3, 4, 5 hours away and they don't want to go there, I think it makes a lot of sense. Outside of the US, where you may not have availability of CAR T like we have in the US, even bispecifics are not available, maybe it makes a lot of sense. But from a pure efficacy standpoint, I think, CAR T and bispecifics are still more efficacious. I think they should be used first, but when it's not available or a patient doesn't want to travel, far away, I think that makes a lot of sense. And some people can be okay on it every 3 months, for example.
Sometimes, though, it's just so hard to get a real feel for how effective a drug is. You can imagine we talk about antibody-drug conjugates all the time in solid tumors. And, it's one thing to look at a study, and then another thing, for example, trastuzumab deruxtecan in breast cancer, you ask any oncologist, they've seen great responses with this ADC frequently. And, here in a situation where it's, much less clinical experience with it, and enfortumab and bladder cancer, first line now. When you think about more granularity, and yeah, I'm not trying to compare it to CAR T or bispecifics, but do you see really effective responses with belantamab?
So I think, my experience is limited to the very late line setting when we used it and the response, 20 to 30% patients responded. And you're right, when patients respond, they can be long-term responders. But I think in the earlier line setting where I have not personally used it since we were not part of those randomized clinical trial would be very interesting to see how the responses translate in the real world. But my experience was about a third of patients responded. And then when they did respond, it could be long lasting. But 70% patients did not respond in the late line setting. But I'm excited to see how this moves to early line.
All right, well, let's go through your cases. How about this 40-year-old man? What happened with him?
Yeah. So this is a 40-year-old man, and I saw him, in the middle of the pandemic, was sent to me for a autologous stem cell transplant referral, was diagnosed and treated in the community, was very healthy beforehand, had no comorbidities, right? And this came out of the blue, coming with, bone lesions and pain. So had ISS stage 1 disease, an M spike of 3.6 gram per deciliter, LDH was normal, lambda light chain was 200 milligram per deciliter. So nothing here which would scream out this patient is going to relapse early or is going to be very high risk, right? His PET CT scan did have multiple hypermetabolic bone lesions. The largest was 3 into 4 centimeters, so had a bone plasmacytoma, but no true extramedullary disease. His bone marrow biopsy had 30% plasma cells. FISH was not available, as sometimes happens in the community. It was not done. So this patient, if I go back, got standard therapy, which at that time, several years ago, was a triplet. At that time, quadruplets had not really taken over, got bortezomib lendex, got radiation to the plasmacytoma, had a partial response in 2 cycles, and that's where I saw this patient for evaluation for auto transplant. And we talked about auto, but within a few days, he called me, I'm having a lot of pain, and he had rapid progression with VRD, something we would never have predicted based just on the biomarkers alone, tells us that we are still not great at predicting every single patient. So what we did was we had a randomized clinical trial open with cilta-cel at that time, and this patient was enrolled on trial and got cilta-cel with dara-pom-dex bridging. And he had a partial response to bridging. And I mean, this patient was going into enrollment with pathological fracture, lots of extramedullary disease, really bad, as you will see on the PET scan, as in the next few slides, really bad disease going into CAR T, but had effective response to bridging. And he had an MRD negative CR to CAR T. And he tolerated it just well. He had grade 1 CRS. He had cytopenias for a few weeks. In fact, they continued beyond the first month, maybe 3-4 months. We managed it. Hypogammaglobulinemia, got IVIG, and some mild seasonal infections, more so in the first year. But I think this patient, who's now 4 years in MRD negative CR, has an excellent quality of life, works full time. You can see here. I saw this patient when his light chains were about 80 milligram per deciliter. In 2-3 weeks, progressed to over 200. But with CAR T, with bridging came down, and with CAR T, he's in a stringent complete response here. Here is the PET scan that we had, and this was done at his referring doctors. Lots of disease in the bone, even some extramedullary sites. And this is PET scan that was done, 6 months after CAR T. Everything has disappeared, right? So sometimes CAR T done early, and this is a patient who was not DARA exposed, but this is a patient who relapsed early, has been life-changing and transformative for this patient, has no delayed toxicity. So truly, I think, saved the life of this young patient.
What an amazing case. Just kind of, this always comes up when you see extraordinary responses. Any thoughts or hypotheses about why this patient is different than some other patient who doesn't have such a great response?
Yeah, I think that's hard to say. I think we know that using CAR T in earlier line setting where this patient got is more effective. Your T cells are more healthy. Also, you're less prior heavily pretreated. And this patient also had an effective response to bridging. But we know that patients with extramedullary disease relapse early, yet this patient has continued on for 4 years. I think we don't know yet. There's many things we are still, at the beginning of understanding with these new therapies. So hopefully we'll have more insights, and we can then take those insights and leverage that for future patients. But I don't know why this patient has gone on for 4 years while someone else might not have.
So hopefully this will continue, but just out of curiosity, if this patient were to have disease progression, what would you be thinking about? And in general,
Yeah.
how do you think through post-CAR T therapy in a patient with a great long-term response versus a short response? How do you think through what's next?
Yeah, I think that's an excellent question, right? So it really depends on what line of therapy they're in. So for, say this is an early line patient. So let's talk about this patient first. So, if this patient were to relapse, he's done so well with one and done CAR T therapy. I mean, somebody with young kids, a full-time job. I would like to take him to a clinical trial of a different CAR T cell therapy available in earlier line, right? To give him the same quality of life benefits his T cells should have recovered by now. Of course, we also have our standard of care options of carfilzomib dex, dara-pom dex. All of that is there for this early line. But I would really like to see if I can do another CAR T in a clinical trial for early relapse, or maybe even ide-cel if we can't, because this was cilta-cel. For if this was late relapse, right? And if this patient had an excellent response, again, I would look for a clinical trial for different CAR T. But if a clinical trial were not to be available, I think bispecific antibodies would be a great option for this patient as T cell health has recovered. And here I would use a BCMA targeted bispecific antibody because it's been so long.
You mentioned a couple of newer CAR T preparations or products, Arlo-cel and Anito-cel. Can you just sort of broadly characterize them and about how they work, what we know about them, and whether or not there's a potential advantage as being the first CAR T to be used?
Yeah, so excellent questions. Anito-cel targets BCMA, so it's another BCMA targeted CAR T. So you'll ask, what's the difference? It's structurally very different than either ide-cel or cilta-cel. So ide-cel, going into technicalities, is mouse-derived, has a scFv, so it's a long structure sitting on the lymphocyte. Cilta-cel is camelid-derived, so llama-derived, actually targets 2 BCMA epitopes, the heavy chain, and this one is synthetic, so it's not derived from any, animal model. It's synthetic designed in the lab is very small. So the CAR T targeting part, the CAR T is actually very small. So theoretically, the hypothesis is it expresses better. You could have more CAR receptors on every cell. It's more, more predictable. But again, the proof is in the pudding. And what we saw at the ASH meeting was, yes, the response rates were quite high, 98, almost 100% response rates with anito-cel. So they presented two sets of data, one with their phase 1 study of about 38 patients that has a follow-up now of 3 years, the other with their phase 2 study of almost 100 patients, and the follow-up is short. So the early study, the follow-up shows 2.5 years PFS, but no delayed neurotoxicity, something that we need to be watchful for with cilta-cel. So that might be the potential benefit, is that the response rates can be quite high. The PFS can be, with cilta-cel, we saw 3 years. This is 2.5 years, but no delayed toxicity. And that's maybe holding true in the phase 2 study as well. We need to see data. So that's the advantage. So if that truly holds true, if efficacy is similar, we might want to use that more in patients who are worried about delayed neurotoxicity, because that takes that trade-off away, right? What we also know is that even though BCMA is BCMA, these might actually work very well even against the same BCMA, because they target different epitopes. So I would hypothesize someone's relapsing after cilta-cel, anito-cel, if we have that available either in a clinical trial or FDA approved, will work quite well, because it targets a different region in the BCMA, right? So I would like to use different CAR Ts for these patients. Arlo-cel targets a completely different protein, GPRC5D, which, as you mentioned, is the target of talquetamab, right? And here, this was a study done in late-line setting, and half of the patients had received prior BCMA-directed therapy, the other half had not. And the median progression-free survival was 18 months, and was similar in prior BCMA and non-prior BCMA-directed therapy patients, which was very impressive to me. Again, the trade-offs are there's some non-ICANS cerebellar toxicity with balance issues, which may be reversible and some may not be reversible in other patients, is what I took away from that ASH presentation.
So before we hear about your other case, just kind of curious about what you observed. This patient you just presented had hardly had any treatment, and now hadn't had any treatment now in several years. But I guess much more typically, these patients have had a lot of treatment and been living in the oncology office, and all of a sudden don't need to come back very much. Just kind of curious what you've observed, how that's played out, how you see it affecting quality of life of patients.
Oh, I cannot emphasize enough, Neil, how these patients love that treatment-free interval and the quality of life. The first couple of months, even when they go back, there's more blood work, everything. But beyond that, if you don't have delayed toxicities, it's once a month blood work, maybe see your oncologist every 3 months, go see your referring provider every 3 to 6 months. So really, they can travel as they could never before. They can spend time with family as they could never before. It is an amazing quality of life difference, and it's one of my best clinic visits, because we don't have that luxury in myeloma, as you said.
All right, let's hear about your other case, a 52-year-old man.
Yeah, so I wanted to present two different cases, as you said, right? This is more typical when patients have had years and years of therapy and they come to CAR T, quite late. So this patient was diagnosed 15 years ago. At that time was 52. When I saw him, he was in his 60s, but that time was diagnosed at the age of 52 with ISS stage 1 disease. We don't have FISH, but we had FISH, didn't really show much, but the complex cytogenetics were there. And so got traditional therapy with bortezomib len-dex triplet, auto transplant, len maintenance, got 2 years from this, stopped for a little bit, then progressed, got len at higher dose and dex, did well for 3 years, and then had everything else under the sun that's approved for myeloma. Carfilzomib, Darapom-dex, Elo-len-dex, and was then sent for a clinical trial, because this was a time we had no FDA-approved CAR Ts in myeloma. We had a clinical trial of an allogeneic BCMA-targeted CAR T. It was investigational. He had a partial response, but progressed very quickly at 1 month. And then we gave him Dara-selinexor-dex, got 4 months, and then it's progressing. So then comes to us, is in my clinic already, and I'm talking to him. We had limited option. That's a time we don't have bispecific antibodies approved. That's a time where ide-cel had just become approved in the market. And there was tremendous excitement, even though, we are not seeing a plateau, but what we saw was twice what we saw with historical therapy at that time. So I talked to him about standard of care ide-cel as a commercial CAR T. And we had very little data about how one CAR T would do after another CAR T, 6 months after. But I was convinced that it was not because of BCMA. We checked BCMA, in our lab. He was positive. I thought it was probably because the allogeneic CAR T cells didn't last long enough. His body rejected them. And he has done so well. So he tolerated treatment very well, just grade 1 CRS, got tocilizumab, but he went into MRD negative CR at 3 months post CAR T, was ongoing for 3 years, as you would see on the right hand side with his free light chains, going up and down. The down first is with his allogeneic CAR T, then went up again, then has really stayed down with with ide-cel for almost 3 years. Now in December last, I saw him 2 months ago. It's going up a little bit. Free light chains are 4 milligrams per deciliter in lambda, and we are starting to talk about what do we do next now for him? Do we do bispecifics? Do we do CAR T? But this is the kind of patient who, for the first time in their life at a treatment-free interval, loves the quality of life CAR T gave him and is talking to me, is there an investigational CAR T he can do? So that's what we are considering when he truly progresses. We're watching him very carefully right now.
Really interesting. What do you think you're going to do? If you were a next clinic visit shows up and really needs to be treated, what would you be thinking?
Yeah, so we have investigational trials of dual targeting CAR Ts. So that's something I would like to do if he's a trial eligible. But if he's not trial eligible, then we can consider things like even cilta-cel. He's at ide-cel. Now, getting insurance to approve 2 commercial CAR Ts is a challenge. So, that is something we are all trying to navigate. That's not always successful. So that's why looking at investigational products first, because I don't think it's realistic for insurance at this time in 2025 to approve 2 CAR Ts. But then bispecifics, right? Talquetamab, teclistamab, or elranatamab would be the option as standard of care.
Do you generally think about the mechanisms of resistance and try to change the target or the class when you sequence after CAR T?
Yeah, I think about that a lot. We can get some data from our lab, whether it's from our clinical lab or from our research lab about the target. So we do look for BCMA expression. It can be quite heterogeneous. What we've seen is if people relapse, BCMA expression does go down, but it's very variable. Some can have dim, some can have very high. If you have dim or no expression, we know that you're probably not going to respond to BCMA targeted therapy. Now, if you have high expression, you still may or may not respond, but not having it is an exclusion for next BCMA targeted therapy. So I try to use that, right? And what I try to see is someone's relapsing after bispecific. We know that another bispecific may not be as effective, but sometimes we don't have a choice because of T cell exhaustion. So we do think about that. So if someone's relapsing early, so if this patient had relapsed within 6 months, I would have chosen a GPRC5D target for him, not BCMA.